So, hello and welcome to the Carilion Nursing Research Conference Lamplighter Keynote Address. At this time, we are happy to present our very own Brandon Jones, System Patient Experience Manager, as our keynote speaker. Brandon describes himself as a hashtag pink socks wearing, engaging, and energetic speaker focused on centering both current and future caregivers on their purpose. Brandon is a registered nurse with 15 years of experience in healthcare, including critical care and emergency medicine, and has been involved in patient experience for the past 7 years. Please join me in welcoming Brandon Jones as he presents Compassion Changes Everything, the evidence-based case for compassionate care for patients and caregivers. Brandon, it's all yours.
All right. Thank you so much. Thank you for your time. It is a joy, a pleasure, and a privilege to be able to maybe introduce you to some new ideas about compassion and perhaps change the way that you view compassion as part of healthcare. So I'm going to flip my video off as we go through this presentation, just so that you can focus on the words on the screen and what we're talking about, as opposed to focusing on me. So this is a research conference, and what we're going to be talking about today is based on the available literature regarding compassion. And there's a lot to go through this afternoon, so we're going to be moving quite quickly. And this is really only going to be scratching the surface for the totality of the evidence-based case for compassion. Now, for the slides that we're going to be going over this afternoon, when you see the light bulb, that's there to notate a key finding, a conclusion, or an idea from the research study that I'm going to be referencing. And each slide that refers to the literature will also have a reference in that bottom right-hand corner. So listen, don't just take my word for it, all right? Go and dig deeper yourself. So for anyone that has ever heard me speak before, this slide that's on the screen now is probably pretty familiar to you. So every moment matters. We talk about moments a lot in this patient experience journey that we're on as an organization. And the fact of every moment mattering is really a burning platform for us in this work. And one of the things that I always tell audiences when I'm talking to them is that this point right here, that moments are ingrained in compassion, is probably one of the most important points that I make during the entire discussion. And when I talk about these moments being ingrained in compassion, I always tell them that your compassion, the compassion that you provide another human being, is powerful. It's powerful. And do you know that I've never once, not one single time, ever had anybody challenge me on that statement? I've never had anybody say, hey, you said that compassion's powerful. Prove it. Can you prove that compassion is really powerful? Well, today I'm going to challenge myself to prove that compassion is powerful. Compassion is immeasurably powerful, but the compassion that you provide other human beings is also measurably powerful. So when it comes to compassion, I think that there's really four main themes when it comes to the lack of compassion in today's healthcare system. And those four main themes are here on your screen. I don't think it really matters. I don't have time. I don't care. And I don't know how. The majority of our conversation today, the majority of what we're going to talk about is in the I don't think it really matters bucket. We're absolutely going to touch on the I don't have time, and we are definitely going to talk about the I don't care, because that is the compassionate care for the caregiver. The I don't know part I'll touch on at the very end. We're not going to spend hardly any time on that at all. That'll be a completely different presentation. So before we get started talking about compassion, we've got to have a good fundamental understanding of what compassion is. Many times, empathy and compassion are used almost interchangeably, but they are two very different things. You'll see the definitions there on your screen. Empathy is a feeling or understanding of another's emotions. It's the emotional experience of another's feelings. Compassion, however, is the response. It's the emotional response to another's pain or suffering, involving an authentic desire to help. Compassion involves action. Compassion is not just some nice thing that we say, it's a verb. Compassion is action. Empathy says, I see you walking. Compassion says, I see you walking and I'm coming alongside of you in your journey. It is the action that we take with another human being to help to relieve the pain or suffering that they are experiencing. So I want to start out in our conversation for the case for compassion with the American Nurses Association, and specifically the ANA's Code of Ethics for nurses. So in provision 1 of that Code of Ethics, it says, as you can see on your screen, the nurse practices with compassion and respect for the inherent dignity, worth, and unique attributes of every person. And historically, developing the compassionate character was the real impetus for care and gave the nursing profession its ethos. I mean, in Florence Nightingale's view, good nurses were good people who cultivated certain virtues or qualities in their character, with one of those being compassion. And patients were expected to be at the center of all nurses' thoughts. That sounds like patient-centered care, right? Even all the way back to Florence Nightingale. Patients were expected to be at the center of all of the nurses' thoughts. Nurses had to always be kind, but never emotional, because they were caring for living people, unlike plumbers or carpenters, as Florence Nightingale said. And as Nightingale reiterated in her letter to the probationer nurses, it is what the nurse is inside that counts. And quote, the rest is only the outward shell or envelope. I've got a few other quotes from Florence Nightingale up on the screen. If a patient is cold, if a patient is feverish, if a patient is faint, if he is sick after taking food, if he has a bed sore, it is generally the fault of not the disease, but of the nursing. Second quote, if you knew how unreasonably sick people suffer from reasonable causes of distress, you would take more pains about all these things. And then the last one is the very first requirement in a hospital is that it should do patients no harm. Put that quote from Florence Nightingale in the back of your mind, because we're going to touch on that one in just a moment. But I do want to encourage you, if you have any time at all, to go to that reference down there in the bottom right-hand corner and read the letters from Florence Nightingale to those probationer nurses. It is absolutely fascinating. So I think it's going to be safe to say that most of us on this call today, most of us who are listening to this conversation, agree that caregivers ought to be compassionate, right? That treating patients with compassion is the right thing to do. The ANA speaks about it. We heard about it from Florence Nightingale, that it's a responsibility and a duty and a moral imperative. But the question that we must answer is this. Is compassion just an ought? Is it just something we ought to do? Or does the evidence exist that shows compassion is a vital and necessary part of the effectiveness of healthcare? Put another way, is there evidence that shows that compassionate, connected care is evidence-based medicine? And that is the question that we're going to answer today. We're going to start with, I don't think that it really matters. So the quote on the screen that I have right now, I'm sure is very familiar to everyone on the call. It's from Maya Angelou. It's a quote that I personally love to use with almost every single set of caregivers that I talk to as we're talking about compassion. And it says, I've learned that people will forget what you've said, they'll forget what you did, but people will never forget how you made them feel. Well, since we're at a research conference and we're not just taking anecdotal things, the question that we have to ask is, was Maya Angelou right? Is this a true statement or is this a false statement? Is it just something that kind of makes us feel good, or is it more? Is it more than just an anecdotal thought that someone had, or is it actually supported by the evidence? Well, to answer this question, we're going to go all the way back to February 27th, 2007, on a snowy stretch of highway outside of Uppsala, Sweden. And that is when two commuter buses packed with passengers collided head on. And one of the bus drivers lost control in the icy, slushy conditions while they were trying to pass a parked truck on the side of the road. And the results were devastating. One of the buses was completely annihilated, and one bus was sheared in half, which you can see on your screen now. And the rescue circumstances of the scene, between the environmental surroundings and the incredible extent of the damage to the buses, was so complex and time-consuming that it later became a reference point in a disaster medicine textbook. Now, as a result of this motor vehicle collision, tragically, 6 people did die, but 56 of them were saved. And 5 years later, researchers asked every single survivor, all 56 of them, a question. And that question, what do you remember most? What do you remember most about that day? What do you remember most about the point of impact? And after rigorously analyzing the qualitative data, 2 common themes arose. The first theme, I'm sure, is expected. You probably already know what that one is. It's physical pain. Many of the patients spoke about the physical pain that they experienced at that moment of impact. But the other theme could be classified as surprising and probably a little bit disheartening. The other aspect of the event that they remembered was the complete and utter lack of compassion from the caregivers at the hospital. And before you say, well, it was just one hospital, it was just one emergency department, that team itself was probably suffering. Yes, that is absolutely true. However, these individuals were actually taken to multiple different hospitals, yet had the exact same experience. A lack of compassion is what they remembered the most 5 years later. So I think that we can say that Maya Angelou, her thought, her quote that we use so often is not just something that feels good. It's not just something that she saw based on what she has learned. We've seen it here based on the experiences of these patients that we're talking about. So as we progress through the discussion about the evidence of compassion, it's vital to keep in mind that the main driver of clinical outcomes is clinical excellence, period. Go back to what Florence Nightingale said. Safety should be our number one priority. Safety is our number one priority. Compassion is not a substitute for safe, high-quality clinical care. If a surgeon botches the technical aspects of surgery, or if a patient receives the wrong medication, there's no way that compassion can make up for that. But I would contend to you today that it is not compassion or excellent clinical care. They are not 2 separate things. They don't have to be done in silos. I would contend to you today that it's compassion and excellent clinical care. And when compassion is used in conjunction with excellent clinical care, it is incredibly powerful. When used together, compassion and excellent clinical care deliver the best outcomes. So our first exploration of the impact of compassion on quality care will be compassion's impact on surgical recovery. So back in 2015, in a randomized controlled trial, researchers randomized 104 patients that were about to undergo surgery to one of 2 treatment arms. They were either randomized into the usual preoperative care or into preoperative care with enhanced compassion delivered by the nurse, the surgical nurse to be specific. So for the enhanced compassion intervention, those nurses did undergo specific training to give that compassionate response to a patient's emotions through what they called explicit compassion-focused behaviors. And the intervention that they did consisted of initially eliciting and exploring patients' questions and personal concerns about the surgery, and then addressing these questions and concerns in a customized fashion through the delivery of personalized information and empathetic response to emotions, through explicit appreciation of these emotions, leading to a sense of validation and understanding. What were the results? Well, they looked at post-op day 1 and post-op day 30. On post-op day 1, researchers found that patients randomly assigned to the compassion intervention had 50% lower levels of pain compared to patients randomly assigned to the usual care. Additionally, they found that patients reported better surgical recovery and higher level of physical activity. So it's important to remember that this first result here is all patient reported, all right? Lower levels of pain, better patient reported surgical recovery, physical activity was better. Now at 30 days post-op, what they found was continued lower levels of pain, but the patients also had better wound healing. And this was not patient-reported better wound healing. This was better wound healing as assessed by the nurse, as assessed by a home health nurse. they had significantly lower levels of pain and better wound healing. So perhaps in addition to enhanced recovery after surgery, we can include compassion. And the researchers noted this in their study: our results indicate that an empathetic, patient-centered approach applied to preoperative interviews reduced anxiety levels and promoted a better post-surgical recovery in patients undergoing general ambulatory surgery. And this study is not unique. These results are similar to results found at Mass General, where anesthesiologists participated in a compassion intervention prior to surgery way back in the 1960s. In these randomized trials of patients about to undergo surgery, the caregivers themselves made a major difference in the patient's care, their recovery, and their healing. And these results were the result of compassionate human connection. So compassion not only positively impacts patients having surgery, but it also impacts patients who experience major trauma. So in a study of 136 trauma patients admitted to a level 1 trauma center, researchers assessed the patient-reported outcome measures, which are the patient's subjective assessment of their own recovery. This was done at 6 weeks and 1 year following discharge from the hospital. Using a validated compassionate care scale, they also measured the patient's assessment of the compassion of the physicians that were caring for them at the trauma center. So the patients assessed the physician's level of compassion. So they took the data and they analyzed it and adjusted it for any demographic or socioeconomic or injury-related factors. And what they found was that the high physician communication group, those patients who were cared for by high compassion physicians as reported by the patient, so the patient's perception of that physician's compassion, was independently associated with a good outcome at the 1 year mark. And the odds of a patient-reported good outcome was 4 times higher if the physician that treated them was compassionate in the handling of their care. All right. So we have talked about some kind of subjective elements of care, right? Even though that one research study did talk about the objective element of the better wound healing. Most of it was subjective. Let's look at some really good objective data. We're going to review 2 studies that measured the impact of compassion on patients with diabetes to see if there was a link between better outcomes. So in the first study, 891 patients with diabetes under the care of 29 different family physicians were enrolled in the study. And physicians completed the compassionate scale survey. So they were assessing themselves for their level of compassion. Based on these results, physicians were placed into one of 3 groups: high, moderate, or low compassion. And data for blood sugar control was analyzed, and it was specifically the hemoglobin A1C. And what they found was that patients of high compassion physicians were significantly more likely to have optimal blood sugar control. In fact, the odds were 80% higher. Now, of course, researchers did run tests on the data to make sure that the association between compassion and better blood sugar control were not influenced by factors like age, gender, or health insurance status. Incidentally, in this study, they also found that patients of high compassion physicians also had better optimal cholesterol control. So in another study, the first study, remember, was 891 patients. Now they kind of upped their game. The researchers upped the number of patients that they wanted to look at. And in this study, they looked at 20,961 patients. You heard me correctly. Over 20,000 patients were enrolled with 242 physicians. And this time, researchers analyzed the association between physician compassion and serious complications of poor blood sugar control, emergency conditions such as like DKA, for example. And researchers found that compared to patients of low compassion physicians, so again, the 242 physicians assessed themselves on their compassion level. They were put into 3 buckets. And they found that compared to patients of low compassion physicians, patients of high compassion physicians had a 41% lower odds of serious diabetic complications, again, such as DKA. Now, this isn't just better blood sugar control. These are the actual complications that can arise from high blood sugar, an endpoint that I would contend really matters here. And these were not small studies either. Remember, the first one was 891 patients with 29 different physicians. The one we just went over, the second one, was over 20,000 patients cared for by 242 patients. So staying in that theme of looking at some objective data, let's look at the evidence for compassion's impact on immune function. We're going to go through a few studies that look at the immune function that compassion can really impact. So in a research study from the University of Wisconsin-Madison, researchers enrolled 350 patients. They were presenting to a primary care office with the common cold. And they asked the patients to complete the CARE measure for their physician. Now, that CARE measure is an acronym, and it stands for Consultation and Relational Empathy. Basically, what it is it's another well-validated survey that measures patients' assessment of their own physician's compassion. So in the previous studies, it was the physician that was measuring their compassion. Now it's the patient that is, again, measuring their compassion. The researchers followed patients over time, and they measured the duration and the severity of their patient's symptoms, as well as a marker of the immune response called that interleukin-8 in their nasal passages. Now, when they compared the outcome for patients of the physicians with the highest compassion score versus those patients of lower compassion physicians as rated by patients, what they found was pretty astounding. They did account for possible confounding factors, and they found that high physician compassion was associated with a doubling of the interleukin-8 levels. That indicates enhanced immune response. They also found a one-day decrease in the duration of those cold symptoms and a 15% decrease in cold symptom severity. So compassion makes a difference, even with the common cold. So here's a question. We looked at the common cold. Could compassion have a meaningful impact on HIV disease? Specifically, what happens when patients believe that their healthcare providers know them as a person? Well, researchers at Johns Hopkins University studied more than 1,700 patients with HIV and asked patients to respond to a very simple question. Does your HIV provider really know you as a person? They analyzed the association between some different elements: being known as a person, adherence to medication, viral load as a best indicator of whether or not the patient's HIV disease was under control. They then, of course, adjusted the data for a number of potentially confounding factors, and I will say it again, what they found is astonishing. So being known as a person, so when patients said, yes, my HIV provider really knows me as an individual, as a person, being known as a person was independently associated with 33% higher odds of adherence to their antiretroviral therapy. And this is a really important point here, because as C. Everett Koop, the U.S. Surgeon General back in the 1980s said, drugs don't work in patients who don't take them, right? It was also associated with 20% higher odds of having no detectable HIV virus in the blood. Now, they also asked patients if they believed that adherence to therapy could help them live longer. This is hope, right? This is hope. And compared to patients who did not feel well known as a person, the proportion of patients who believed that the medications could help them live longer was 39%. It was 39% higher among those who said that their healthcare provider knew them as a person. And lastly, the researchers found that knowing the patient as a person was associated with 41% higher odds that the prescribed antiretroviral medication matched the best practice recommendations for treating HIV. So now we've moved away from patient perceptions, and now we've moved into the actual treatment of these patients. And just to reiterate, what they found was that the patients who said, yes, my HIV provider really knows me as a person, had higher odds of their therapy matching the evidence, matching best practice. So we have gone through the many ways that compassion impacts quality care. And this, again, is really just scratching the surface of all of the available evidence that's out there. But I think I want to pause for just a moment and ask the question. There's a question that we must answer about these associations, and it's why? How are these things possible? Well, no one is precisely certain, and there are a multitude of potential mechanisms by which these things occur. I will give you four. A higher level of healthcare caregiver commitment, i.e. going the extra mile to ensure optimal clinical outcomes. A higher level of patient trust in caregivers, or creating a better therapeutic alliance. Higher quality standards, meaning more diligence and meticulousness around the technical quality of care among caregivers. And more patient self-disclosure in medical interviews that result in better information gathering by caregivers and a better diagnostic accuracy. Now, there are also a number of possible physiological effects that your compassion, the compassion that our caregivers, that you on this call, that you provide, has on another human being. So we've looked at studies that have included quite substantial incisors. Everybody likes to talk about the incisors. Well, we have looked at studies that include quite substantial incisors, as much as 20,000. But what I want to do is take just a moment and look at the impact of compassion with an N of 1. Because when we talk about compassion, it really does occur within an N of 1. It occurs one smile at a time, one act of compassion at a time, one act of kindness at a time, one element of human touch at a time. It occurs one person at a time. Now, we are really fortunate, I believe, to have Swartz Center rounds here at Carilion. But I wonder how many people really know the story of Kenneth Swartz and how the Swartz Center was started. And Kenneth Swartz, of course, is the person that started this movement. So this movement really started after receiving a diagnosis of advanced lung cancer in late 1994. Kenneth Swartz, a 40-year-old non-smoking healthcare attorney with a wife and a 2-year-old son. And this movement started with an observation that Kenneth Swartz made and wrote about in a Boston Globe magazine article entitled A Patient's Story. And in it, Swartz observed that his ordeal was punctuated by moments of exquisite compassion from his healthcare providers. And he was struck by how that compassionate care could transform his experience and actually alleviate his suffering. Here is a small bit of that article. In my new role as patient, I have learned medicine is not merely about performing tests or surgeries or administering drugs. These functions, important as they are just the beginning. For as skilled and as knowledgeable as my caregivers are, what matters most is that they have empathized with me in a way that gives me hope and makes me feel like a human being, not just an illness. Again and again, I have been touched by the smallest kind of gestures, a squeeze of my hand, a gentle touch, a reassuring word. In some ways, these quiet acts of humanity have felt more healing than the high-dose radiation and chemotherapy that hold the hope of a cure. Caregivers need to be trained and encouraged to engage with their patients. My understanding is that medical school training now emphasizes to a greater degree the importance of the physician-patient relationship, and let me just editorialize here a little bit and include the caregiver-patient relationship, the nurse-patient relationship, a bond that ultimately reaffirms the humanity of both. The secret of the care of the patient is caring for the patient. Additionally, Swartz wrote that compassion makes the, quote, unbearable bearable. And throughout the article, he spoke about how his caregivers crossed the traditional professional Rubicon to know him as a person. It's interesting that he also spoke about one of his physicians in quite a bit of specificity. So he wrote about one specific physician scientist named Dr. Kurt Eiselbacher. Now, Dr. Eiselbacher was a renowned expert in clinical trials and was helping Schwartz to navigate the experimental therapy that might be the best to try to extend his life. Dr. Eiselbacher cared about Kenneth and impacted him with great compassion and gave him hope. Schwartz wrote in the same article, "I was especially affected because such hopefulness was not coming from a faith leader, but from a distinguished researcher." And it's clear that this physician who was caring for Schwartz knew that science and compassion were complementary. Now, for Schwartz, as you've seen here, compassion was vital, vital medicine. Now, he did die in September 1995, less than 1 year after his diagnosis. But his powerful message resonated with people and has echoed for decades. Schwartz Center rounds are regularly scheduled times where healthcare providers convene to discuss the social and emotional issues that they face in caring for patients and to share their experience and feelings on topics. And these Schwartz rounds, have been shown in the literature to improve caregivers' ability to give patients the compassionate, connected care. And please allow me to just do a quick plug for our next Schwartz Center rounds, which will take place on Tuesday, November the 30th. From noon to 1 p.m. It is a virtual gathering. There's no pre-registration required. So for more information, please reach out to your leader. It can be found on Inside Carilion. You can go to theschwartzcenter.org as well. So we've talked about compassion's impact on quality care. But what about compassion's impact on safe care? We've talked about compassion's impact on some outcomes that patients experience. But I want to switch gears and pivot just a little bit and talk about compassion's impact on safe care. So I'm sure that this is not new to anyone on the call, but back in 1999, the Institute of Medicine did a study and they published it in this book called To Err is Human. And what they found was that experts estimate that as many as 98,000 people die in any given year from medical errors that occur in hospitals. That's more than die from motor vehicle accidents, breast cancer, or AIDS, the three causes that receive far more public attention. Now, for comparison, back in 1999, the CDC reported roughly 2.4 million U.S. deaths. That puts the errors at approximately 4%. The above estimate represents approximately 4% of deaths for patients. So what's the most recent data showing us? Well, according to the World Health Organization, the occurrence of adverse events due to unsafe care is likely one of 10 leading causes of death and disability throughout the world. In high-income countries, it is estimated 1 in every 10 patients is harmed while receiving care. Most recently, researchers conducted a systematic review of the available literature on in-hospital adverse events. Ultimately, they were able to have 8 studies, including a total of 74,000 patient records that were selected as part of their inclusion criteria. What they found was that the median overall incidence of in-hospital adverse events was 9.2%. More than half of the patients who experienced those adverse events had no or minor disability. All right. However, what they found was that 7.4% of the events were lethal. Patients came to the hospital looking for help. They came to the hospital looking for hope. And through the actions of caregivers, through the processes that organizations had in place, 7.4% of them didn't leave the hospital because those events were lethal. Now, as part of the World Health Organization and in this study, they included a number of proposed evidence-based interventions, all right? Some evidence-based interventions such as localizing care to high-volume centers, ultrasound guidance of central vein catheterization, clinical pharmacist consultation services, quite a bit of the stuff that I am proud to say that we have implemented here at Carilion. And the World Health Organization, they also include some key strategic action areas such as developing guidelines and tools and engaging patients and families for safer healthcare. However, both of these groups fail to mention compassion. And I'm going to show you in the next few slides how compassion is evidence-based for improving patient safety. So in the first study, we're going to look specifically at nurses, all right? So researchers enrolled 309 nurses into the study. The nurses were asked to complete a self-assessed compassion scale, so they were assessing their own compassion, and they completed a self-reported medical error tendency scale. It's an evidence-based tool that looks at their tendency to have medical errors. Now, I do want to note that the nurses that participated in this study, their tendency to make medical errors was already low, okay? What the researchers found was that the nurses' tendency to make medical errors decreased as their compassion levels increased. And that compassion was an important predictor of the tendency to make medical errors. So compassion and medical errors had an inverse relationship. As compassion increased, medical errors decreased. Let's look at a larger study. So in Switzerland, researchers enrolled 1,425 physicians and nurses working this time in an intensive care unit. They used regression analysis to investigate the effect of burnout as an indicator of psychological health, demographics, and organizational characteristics on standardized mortality ratios, length of stay, and clinician-rated patient safety. What they found was that emotional exhaustion, a precursor to compassion fatigue, not providing compassionate care among the ICU staff, was associated with a higher ICU mortality. So now we're not just talking about an error rate like we did in the last study, we're talking about a death rate. And the death rate was higher for those who had a higher level of emotional exhaustion, compassion fatigue, or burnout. What are some of the other studies that look at this? Well, I've got a few up on the screen right now. Physicians who scored high for depersonalization were significantly more likely to commit a major medical error in the next 3 months. Physician compassion was associated with lower odds of committing a major medical error in the next 3 months. Depersonalization among physicians was independently associated with higher incidence of self-reported substandard care at least monthly. Both depersonalization and emotional exhaustion were significantly associated with higher incidence of major surgical errors, and 1/3 of emergency physicians with compassion fatigue reported a reduction in their quality standards in a way that could harm a patient, and that's self-reported reduction. Now, you'll notice that all of these studies on the slide right now are specific to physicians. That's because there's not a lot of literature out there from the nursing perspective. So since this is a nursing research conference, I'm going to put this out there and have a challenge and call on our nursing research community to expand nursing specific research in this area. So far, we've looked at the lack of compassion, how it can reduce the quality of care and the impact that it has on safety and the impact that it has on physical harm. So the reduction in quality care and the impact on safety, those things lead to physical harms. But are those really the only outcomes that matter? What about the harms to patients that do not leave a mark on the outside, but rather on the inside? So what I want to do is I want to invite you to take just a moment and imagine some scenarios that I'm going to read. I'm going to walk through a few scenarios here, and I want you to just imagine, put yourself in the patient's shoes as they experience these scenarios. So a patient with a recent diagnosis of cancer, and let me give you a caveat here. None of these scenarios or examples came from Carilion, okay? So there's your caveat. So here's your first scenario. A patient with a recent diagnosis of cancer goes to the emergency department due to a complication of chemotherapy. The emergency department physician reads through his medical records from the oncology clinic and says bluntly, very matter of fact, since your cancer is incurable. Wait, incurable? The patient's oncologist had not yet used those words with him. And this is the very first time that the patient has heard this information. Here's another scenario. A physician has to notify her patient about test results, and the test results are not good. The physician has to give her the bad news. Now, no one thought to ask the patient ahead of time how she wants to receive the information or who she wants to be around for support when she receives it. And the phone call from the physician comes when the patient is away from home. In fact, the patient's all alone and she's driving 65 miles an hour down the interstate. A morbidly obese woman is admitted to the hospital. Speaking to a colleague, a resident physician makes a judgmental, derogatory statement about her obesity after he steps outside the patient's room. What the resident physician does not realize is that the patient is still within earshot, and she heard everything and is humiliated. And it's not the first time in her life that she's been humiliated by someone because of her weight, but this time it's different. This time it's her doctor. And the last one, a son receives a 3 a.m. phone call from an ICU resident physician asking for his consent to do an emergency procedure on his elderly father. The son's response, wait, in the ICU? My father's not in the ICU, but actually his father is, and his father's dying. And hours earlier on the cardiology floor, the patient suddenly and unexpectedly went into cardiac arrest. And with all the various caregivers' efforts to absolutely work to keep the patient alive, no one remembered to call and update his family. These are all true stories. They are very real emotional harms that occurred in other hospitals and other type of healthcare institutions daily. And they were published by the New England Journal of Medicine. And specifically in the New England Journal of Medicine, they asked healthcare providers to imagine scenarios such as those ones that I just read out. You know, we're not just talking about physical harm. We're also talking about emotional harm. And researchers at Beth Israel Deaconess Medical Center in Boston are studying this problem of emotional harm. And they define emotional harm as harm to a patient's dignity caused by a failure to demonstrate adequate respect for the patient as a person. And importantly, they believe that emotional harms are just as important as physical harms to patients and should be treated accordingly. And I agree. In fact, what they said was that our approach to harm evolved. We gradually realized that we were focusing solely on physical harms and did not have a systematic approach to emotional harm. So here's a question for each person on the call right now. How are we dealing with emotional harms? How are we quantifying emotional harms, or are we just looking at physical harms? So as we have talked about compassion, I want to again make the point, again and again and again, that the main determinant of a good clinical outcome is clinical excellence, period. That no amount of compassion can make up for poor quality care. However, a lack of compassion can predispose caregivers to giving suboptimal care. We've seen that throughout the literature. And a patient's risk of harm can actually be higher in the absence of compassion. To be clear, a caregiver who doesn't demonstrate compassion didn't just miss an opportunity to improve an outcome, but they are more likely to harm a patient. I am ringing the alarm bell for every single person on this call right now that a lack of compassion poses a serious patient safety risk. We are not talking about soft skills. Compassion is not a, quote, soft skill. We are talking about essential skills that are essential to safe, high-quality care. So we're going to shift gears now and look at the I don't have time perspective. So I know I don't have to tell anybody on this call right now that our caregivers are busy, right? And one reason that caregivers may not show compassion is because they're concerned that it's going to take time that they may not have, that they feel like they just don't have. In a Harvard Medical School study, 56% of physicians believe that they don't have enough time to treat patients with compassion. I wonder if we were to ask the nurses here at Carilion Clinic, do you believe that you have enough time to treat patients with compassion? I wonder what our results would show. Now, fundamentally, this is based on a belief that compassion is extra work. Feeling like you don't have time for compassion means fundamentally that compassion is viewed as extra work, but it's not. It's something that's done within the confines of the work that we're doing. But if we go on the basis that compassion interventions take extra work, we've got to ask the question, how much time does it take? How much time does it actually take? Well, researchers from Johns Hopkins University performed a randomized controlled trial in cancer patients during consultation with an oncologist. And the main outcome here was a measure that was well validated, a scale of anxiety, which is avoidable suffering. They then compared it to those patients who received a standard consultation. And what they found was that those patients who were in the bucket of enhanced compassion had significantly less anxiety at the end of the consultation. So, what was the intervention? Well, instead of telling you about it, allow me to read it. I know this is a tough experience to go through, and I want you to know that I'm here with you. Some of the things that I say to you today may be difficult to understand, so I want you to feel comfortable in stopping me if something I say is confusing or doesn't make sense. We're here together, and we will go through this together. And then at the end of the consultation, the oncologist would close in this way. I know this is a tough time for you, and I want to emphasize again, we're in this together, and I will be with you each step along the way. So, how long did that take? Well, I've, of course, practiced this presentation many times, and I've reviewed this slide here many times. And on average, for me, it took around 30 seconds, 28 seconds to be exact. And patients randomized to this enhanced compassion intervention rated the oncologist as warmer, more caring, as well as sensitive, and compassionate care had a lower measurable anxiety impact on that patient. So that's one study. Are there any other studies that are out there that talk about the time duration? Yes, there absolutely is. And you can see the individual studies there on the left and the time that it takes that they found of the intervention there on the right-hand side. So the median time in all of these studies to do a compassionate intervention, around 40 seconds. Around 40 seconds. So now with that in mind, 40 seconds, think back to that study from Harvard Medical School where they showed that 56% of physicians believe that they didn't have time for compassion. So here's another question that we're going to pose. Is this reality or is it perception? And I would espouse with the idea that perhaps this isn't about actual time, but rather the perception of time. So let's go to the literature and look. Way back in 1973, a group of researchers studied students at Princeton Theological Seminary, and they randomly assigned the seminarians to either an intervention arm in which they received a talk on the biblical parable of the Good Samaritan. Now, that's a message of compassionate helping for a stranger in distress. Or the control arm that received a talk about an unrelated, non-helping topic. Immediately after, the students were instructed to walk to another building for their next assignment. And on their walk, they encountered a stranger in need, disheveled, lying on the side of the road between two buildings, moaning, obviously in distress. And this was an actor who was part of the experiment. And what they found was that overall, only 40% of the seminarians stopped to help the man in distress. And those randomly assigned to hear the Good Samaritan message, well, they were no more likely to stop and help than the control group. The message didn't matter. However, the most striking finding in this study was what they considered to be the major determinant of compassionate helping, which I have not told you about yet. So one thing that I left out was that initially the seminarians were randomly assigned in another way. All the seminarians were instructed to go to another nearby building on campus for their next assignment. And in doing so, they would have to walk right by this person that was in distress there in the alleyway. Now, the extra layer of randomization was that half of the seminarians were randomly told that they did not need to rush. This is what they called the no hurry condition. And the other half were given the exact same instructions about which building to go to next, but this time they were told that they were already late for their next assignment and they needed to hurry. And this is what they called the hurry condition. And of note, the seminarians were not really late for anything, right? They were just made to believe that they were in a hurry. Those in the hurry condition group were significantly more likely to pass by the person in distress without stopping. Specifically, 63% of the no hurry group stopped. However, 10% of the hurry group stopped. Researchers found that believing to be in a hurry was the only factor that predicted whether or not the seminarians would stop. So is it possible that this disconnect between the perception, that there is a disconnect between the perception of time and the actual time, and that this disconnect is a major contributor for a lack of compassion in healthcare today? So now let's look at the I don't care group as we finish up our time together. Now, let me start out by saying that the idea that caregivers don't care about providing compassion to patients is one that I don't believe is something that is intentional. I refuse to believe that we have caregivers anywhere that come to work and intentionally say, I'm not going to provide compassionate care. But this lack of compassion really arises from the epidemic of emotional exhaustion and depersonalization, what is typically described as quote, burnout, right? So in your own experience, I know that each person on this call is acutely aware of the prevalence of burnout symptoms among caregivers. Regardless of job role in healthcare, it's enormous and it's growing. And the literature supports this. Back in 2017, well before the unbelievable stressors that were placed on nurses by COVID, researchers found that 85% said that their jobs were making them fatigued. 63% noted their work has resulted in nurse burnout. 63% and 44% reported being worried that their tiredness was going to cause their patient care to suffer. This is nursing specific, and additionally, we know from the literature that approximately 50% of U.S. physicians are suffering burnout symptoms. And there's a human cost of this burnout. We know that physicians experience the highest suicide rate of any profession. But what about for nurses? You know, the ANA notes that nurses are at a higher risk of suicide than the general population. However, unfortunately, it's not really known. And according to researchers at the University of California, San Diego, there is an alarming lack of data on nurse suicide rates. And considering the extreme pressures that our caregivers are placed on every single day, the National Academy of Medicine is concerned that the nurse suicide rate is a hidden tragedy. And they note that until such data are available, silence and the preventable loss of life will prevail. And before we go any further, I want to stop and make sure that you hear this very loud and clear. If you are experiencing feelings of emotional exhaustion, compassion fatigue, burnout, or suicide, first know this: it is okay to not be okay. You are not alone, and to please reach out for help. The National Suicide Prevention Lifeline is there on the screen. There's a lot of resources here at Carilion Clinic. You can find those on the nursing specific side on the nursing services intranet page. The ANA also has resources that are available at nursingworld.org/practice policy/nurse suicide prevention. Please, please reach out. Burnout is not just a serious concern for patient care, but also for our caregivers, for those who are caring for our community. And I know that this is something that you know. So how does compassion tie into all this? As we wrap up in the next few slides, we're going to talk about compassion's impact on caregiver burnout. Now, as we've already discussed, burnout is complex and there are many solutions. Now, I know that you all know that there isn't a shortage of lectures or webinars or conferences out there that all claim to have the solution on burnout. Yet it still remains an unconquered challenge. So I want to present to you today one that is contrary to a lot of thinking. Recently, 2 independent groups published rigorous meta-analysis in The Lancet and JAMA International Medicine, showing the effectiveness of interventions to combat burnout. There's some interventions at the individual level and some at the organizational level. And the striking thing about what they found is that the vast majority represent escapism. And that's built upon the belief that if you just spent less time caring for patients and in favor of more self-care, that burnout would no longer be a problem. Now, research does show that many interventions based on escapism do reduce burnout to some extent. Absolutely, a better work-life balance is essential. Making sure that your tank is full so that you can come back and pour into others is essential, but it's only part of the solution. I would like to push us to look closer to the point of care for an intervention for burnout, where we lean in, rather than pull back. Now, I think it's intuitive to some extent that there could be a risk of burnout with repeated or excessive exposure to human suffering. Absolutely. However, there's enormous literature to support a different view, that human connection can transform the experience for the giver of compassion, trigger positive emotion, and build resilience. And this is not a new concept. For millennia, philosophers and thinkers have intuitively understood that compassion for others could be beneficial for one's own well-being. And quotes from many of these philosophers and thinkers are on the screen right now. So the traditional thinking is that compassion and burnout have a positive correlation. That is, the more compassionate we are, the more burnt out that we're going to be. However, a systematic review of the evidence finds that the majority of data shows the exact opposite to be true. The association between compassion and burnout has an inverse relationship. Inverse. High compassion is associated with low burnout. So I want to make a quick note about this correlation. It could be interpreted that the inverse relationship is that burnout crushes one's ability to be compassionate, right? A belief that burnout actually drains you, drains you of your compassion. However, when you really look at it, high compassion is protective against burnout. It's protective against burnout. Nurses with functional MRI evidence of low activity in compassion centers of the brain scored the highest in burnout. Greater physician compassion was associated with greater well-being. High compassion is associated with lower depression symptoms, a higher sense of personal accomplishment, and enhanced quality of life. Among emergency nurses, more compassion is associated with higher scores for well-being. Compassion for others is good for you. Compassion for others is good for our caregivers. It is protective against burnout. So again, I know that we have not talked about the I don't know how. That's going to be a completely separate discussion, because the more research that I do on compassion, the more that I'm absolutely convinced that you can teach compassion interventions. So at the end of the day, what we're talking about is a choice, right? We can't mandate compassion, but I would ask that you join us in this journey, that you make the choice for safe, high quality, compassionate, connected care, because a missed opportunity for compassion can change the trajectory of one's life for both the patient and the caregiver forever. It's a choice that every single one of our caregivers make every single day. So compassionate care, why bother? Here's why we should bother, because not every day is going to offer you the opportunity to save someone's life. However, every single day and every single interactions that our caregivers have with those that we are here to serve offers the opportunity to impact someone's life. And our caregivers, you on this call, our caregivers impact lives in ways that you will never, ever understand. And compassion, as I have shown you over the last hour, helps to increase that impact through the provision of safe, high quality care that is protective against burnout. So with that, I'll say thank you. I know we came right up into the mark of the 1 hour time frame. I appreciate your all's time and attention to this very, very important topic. If we can discuss it anymore, please do not hesitate to reach out. And I'm going to make the plea that I made about midway through this for the nursing community, the nursing research community, to really invest more time, energy, and effort in the impact of compassion on patient outcomes from a nursing perspective. So with that, I'll say thank you very much.
Thank you, Brandon. Everybody have a good afternoon. Thanks for joining us.